Good morning, ladies and gentlemen. So welcome to the last day of the CCP Conference 2025. And we have to start a plenary on the management of hypertriglyceridemia by Professor Fredrik Karpe. And I'm now going to invite Professor Chandrika Wijeyaratne to introduce the speaker.
Thank you, Praveen. Professor Fredrik Karpe, I'm delighted to introduce him as a physician scientist at the University of Oxford, graduating and training in medicine. He's done his PhD at Karolinska Institute in Sweden, and he heads the Oxford Lipid Clinic Service and is currently developing the joint AAC-EASD guidelines on the management of dyslipidemia. His main research interest is in human metabolism in relation to obesity and adipose tissue function. This involves studying human adipose tissue function from a genetic, cell biological, and human physiology point of view, and for the purpose of forwarding translational medicine. He has established the Oxford Biobank, which is uniquely designed to allow for a recall by genotype studies from a 9,000 people strong, well-phenotyped local population. His extensive publication record includes more than 300 original publications with an H-index of 85. The topic he has chosen for today is management of hypertriglyceridemia. And Professor Karpe, the floor is yours.
Thank you so much for the kind introduction, and chairperson. I'm delighted to be here, and I'm absolutely delighted to be at the meeting overall, which has taught me so many things, meeting all the delightful and knowledgeable clinicians here in Sri Lanka. So I've chosen the topic, it's my favorite lipidology topic, raised triglycerides. And it sounds as a very practical talk about management of hypertriglyceridemia, but I hope I won't disappoint anyone by not talking so much about actual management, instead focusing on the principle behind the management and why we have arrived into the way we deal with the patients today. And for anyone who would like more firm guidance on practical management, I strongly advise to read a very thorough document that is coming out, I think, next week. It's embargoed, so I'm not allowed to show anything more than the title. But it is a very impressive piece of work that I'm quite proud to be part of. It's a joint work between the American and North and South American Association for Clinical Endocrinology and the European Association for the Study of Diabetes. So it's a huge cover of the world. And one of the things that is impressive with this committee was the vetting for association with pharmaceutical industry. So I think this is one of the few places I, with hand on heart, can say this has no influence from industry and is an unbiased view of how to best manage patients with hyperlipidemia today. So, what I'm going to cover today is first a little overview of triglycerides, the actual measurements, what it stands for, and some principles about triglyceride metabolism. And then I move over to the evidence for cardiovascular disease in relation to raised triglycerides. And I'll also focus on the associations with hypertriglyceridemia-induced pancreatitis. Then current management, but perhaps not so much about management, as I said, more about the principles of why we do things as we do now and want to do in the future. And finish off with a couple of novel approaches that are very exciting because there are actually new, very effective drugs coming in this area. So, with some element of stubbornness, I'm sharing with you a slide that I showed the other day. But for another purpose in this talk. And the purpose here is to emphasize that the pool of triglycerides that we have in the blood is a very small one compared with the other pools we have, for example, in adipose tissue or also in the liver. So there's a huge element of sequestration and compartmentalization. And that's where the problem is with raised triglycerides in the blood. It's either an inability of the organs to actually store the fat properly, or an over-secretion, overproduction of triglycerides from the liver in particular, most likely directly dependent on an expanded adipose tissue. So obesity is key in this, as you will see later on. So it's a bit of an enigma with raised triglycerides in plasma and the relationship with atherosclerosis or cardiovascular disease, because it wouldn't require very much of intuition or understanding of metabolism to know that triglycerides is, of course, a part of a nutritional chain, and it's not obvious that triglycerides per se are related to cardiovascular disease. So that requires some type of explanation. And there are three elements of explaining why triglycerides as a factor in the blood actually relates to cardiovascular disease. The three explanations is, first one would be the focus on atherogenic lipoprotein particles. And clearly, very low density lipoprotein particles, that is the main container of triglycerides in blood, is a direct precursor of the most atherogenic particle we know, low density lipoproteins. And they are structurally similar, except for the larger content of triglycerides in the VLDL compared with the LDL. The next element of explanation is something that was talked a lot about 10 or 20 or 30 years ago. That's the association between raised triglycerides and how that could actually alter the conformation and structure of low-density lipoproteins. So you end up with LDL particles that are small and dense and presumably atherogenic. There are no measurements for this in routine clinical practice, and it's fallen a little bit out of favor as an explanation, but I think it's perfectly valid still. And the last element of triglycerides in blood and how that could affect atherosclerotic process is its involvement in as a decoy or inhibiting fibrinolysis. There is quite a substantial amount of research on this. It's mostly of association type, but all the associations are strong, and I wouldn't be surprised if this is actually a possible explanation as well. So you see here, there are three different ways of looking at the problem, and it could be that in some people, one is dominant, and another person, another explanation is dominant. So bear this in mind when you come on later and see the difficulty interpreting the result of actually attempting to lower triglycerides using pharmacological methods. So what we are aiming for here is, of course, causation. And if you look at the little triangulation I have here between triglycerides with a direct arrow to cardiovascular disease, that's what we are interested in. And it's obvious of the factors I've listed here, and it's obvious if you put type 2 diabetes into play, that type 2 diabetes could have two independent arrows, one to triglycerides and one to cardiovascular disease. So that would be an indirect association and not a causal association. So, just a few introductory words about pancreatitis, which, of course, from a mechanistic point of view, would have a completely different presentation or mechanism of action in a human being. The favorite way of explaining why raised triglycerides in blood actually causes hypertriglyceridemia-induced pancreatitis is that there is always a small retrograde leak of pancreatic lipase from the exocrine pancreas into the blood. And that small leak of active lipase in the wrong direction is, under these circumstances, when the plasma triglycerides are very high, facing a perfect substrate. And free fatty acids are then released in an environment that cannot accommodate any raised concentrations of free fatty acids. And those free fatty acids could then have membrane disrupting properties and really disturb blood flow through the pancreas, and in that way cause local inflammation and further disruption to the transport of pancreatic lipase, with more lipase coming in, and you have a full-blown pancreatitis on the go. So for pancreatitis, there we have this quite strong and secure relationship with the actual triglyceride concentration and the risk of pancreatitis. And it looks like this if you take a blood sample. It's an old picture to the right, but if you look at the middle blood sample here, it looks like single cream. And it is actually concentration of triglycerides that is just like single cream. If you look at the concentration of triglycerides in single cream, it would be in the range of 50 millimoles per liter. And that's exactly what we see in patients who suffer from hypertriglyceridemia-induced pancreatitis. And this is, of course, a water displacement syndrome as well. So if you measure sodium in the same patient with conventional methods, you get hyponatremia, which is not true because it's just a water displacement. So this is a syndrome that is easily recognized. You just look at the blood, and in someone, before you have separated the blood even, the blood is not red, it's pink. And if you separate the plasma is not yellow, it's white. So it's immediately obvious. And the patient in front of you could well show one of the cutaneous stigmata that we know of for very drastically raised triglycerides, the eruptive xanthomata that are spread in the upper part of the body and the arms and on the back as little raised pimples like this. So let me now go through some of the main causes as we think of raised triglycerides. So we start off with what would come close to home here, and that would be diabetic dyslipidemia, obesity-induced dyslipidemia, by far the greatest entity for us in the lipid clinic. The risk for cardiovascular disease is well established with that type of dyslipidemia, whereas the pancreatitis risk is probably less prominent. If you go to alcohol-induced hypertriglyceridemia, you have an extremely raised pancreatitis risk, perhaps not always at all related to the raised triglycerides induced by alcohol, but rather alcohol itself. So here we have a situation where pancreatitis can arise for two reasons. Third one, I just want to emphasize the element of genetics. Genetics is actually a strong determinant of triglycerides, and the polygenic element of raising triglycerides is also strong. I'll show the next slide on that before I just finish off this one. The polygenic trait for raised triglycerides can flip over to extreme hypertriglyceridemia. And that trait would then, if anyone with lipidology interest is interested in the old nomenclature, the Fredrickson classification, that would be a type 5 hyperlipidemia. That is the end stage of an extreme hypertriglyceridemia of polygenic background. The rarer cases, but with very strong associations to both cardiovascular risk and pancreatitis risk, is lipodystrophy. We have a number of patients where we actually see that the presentation of lipodystrophy, or the identification that the patient actually has partial lipodystrophy, is actually found in the intensive care unit when the patient presents with pancreatitis. And finally, the very rare entity, but incredibly scary, is familial chylomicronemia. In the old classification, that's called type 1 hyperlipidemia. This is rare, this is monogenic, it's always involving dominant or recessive genes in homozygosity of disrupting the key function, lipoprotein lipase elimination of triglycerides. And in this area, there are actually some very, very exciting future development in terms of therapeutics I'll come to in the end. So now the next line I want to put in here is that if we just take the triglyceride concentration per se, and look at that, we see that's rather unhelpful. We can't use that at all to differentiate between these causes. So we need the added information to put people into these classifications. And it's rather obvious that the obesity and diabetic dyslipidemia, then you would require a raised HbA1c, and very, very often you would also see abdominal obesity with that. And for alcohol-induced hypertriglyceridemia, there would be an alcohol indicator. Polygenic hypercholesterolemia, familial combined hyperlipidemia or hypertriglyceridemia, there you very often see a family history of both cardiovascular disease but also hyperlipidemia. For lipodystrophy, it's a striking effect on fat distribution, and for these the monogenic parts of lipodystrophy, you would invariably have a very strong family history for early presentation of type 2 diabetes, fatty liver disease as well. Whereas the familial chylomicronemia, there, family history is not often there because these are recessive disorders. So you see family associations in truly consanguineous situations, but not outside that. And one stigmata here that is very clear is that if we are going to name something likely familial chylomicronemia, this should be a patient who never has normal triglycerides. It would always be 5 or 10 millimoles per liter on the best possible non-pharmacological treatment. So let me just dwell for a second on the importance of that, and that's coming back to the familial combined hyperlipidemia, because that is actually a real killer. It's a condition that is common. It is associated with a very, very high risk of cardiovascular disease. And here is data taken from a fairly recent study from the UK Biobank comparing the risk of incident cardiovascular disease with familial hypercholesterolemia, perhaps the lipid disorder most well known for early presentation of heart disease. And you see here that they are completely in the same league of order in terms of severity of risk. This is despite a very loose definition of familial combined hyperlipidemia. What is required in this particular study was the 90th percentile of ApoB, the 90th percentile of triglycerides, and a family history of cardiovascular disease. A very loose definition. It really emphasizes that a possible genetic condition, a family history condition, and raised lipids like this is a very high-risk syndrome, much overlooked actually. So, a little bit more about the genetic evidence for raised triglycerides, and we come back now to this enigma of triglycerides and the risk of cardiovascular disease. So here is a compilation of data from Berger Nordestgaard, excellent review a decade ago about the genomic evidence for triglycerides. and cardiovascular disease. And he has chosen some of the favorite genes involved here. And lipoprotein lipase is, of course, there, showing this clear effect if you carry several common variants in the same gene, and how that can predispose to the association with cardiovascular disease, and of course to the association of raised triglycerides. So these genes, they have been used very much for the triangulation for Mendelian randomization, giving this causal relationship between raised triglycerides and cardiovascular disease. This is not without this is not a very or a completely clean way of studying things, because it's now acknowledged that many of these genetic instruments are actually what we call pleiotropic. They don't work only on triglycerides, they also work on some of the cholesterol pathways, which means that the conclusions from these type of Mendelian randomization studies are not absolutely certain. So, now I'm moving over to some of the historical and very interesting developments over quite a few decades, and that is how we have used triglyceride-lowering drugs and what the evidence is for the use of these drugs today. And I'll start off with what is perhaps this sort of stable horse, the most useful triglyceride-lowering agent we have, and these are fibrates. And here again is a compilation of data from Berger Nordesgaard's review, and he has put together the data from all the fibrate randomized controlled trials to date, and plotted the potential for triglyceride reduction using one of these agents in these trials against the log odds ratio for reduction in cardiovascular event. And it seems to fit a very strong straight line, making the strong suggestion that this is actually a relationship that is useful and causal. What is the truth behind this is, of course, that at this point in time, none of these studies had independently shown an association for prevention of cardiovascular disease. Not a single one of them. And there was a problem with that, because all of these studies were actually had what I would say design faults. And one of the design faults was that they didn't actually include the majority of patients with raised triglycerides. They included a general population of people with raised cardiovascular risk, but the drug was not used for the intended purpose, as I see it, in those studies. And the study that actually did the right thing in the end was a study published only a few years ago called Prominent, with a new and more potent triglyceride-lowering fibrate. And I've taken the liberty of plotting the result of the Prominent study into this graph. And here is where Prominent falls. So it comes with a good triglyceride-lowering effect, but a zero effect on cardiovascular prevention. So this has killed off fibrates for any use for cardiovascular prevention. This is not a drug that should be used for that purpose any longer. And I think we are fairly certain about that. So that was one of our safe bets that no longer is possible to use. So how do we deal with diabetic dyslipidemia up until now? Well, it was obvious that you need to correct glycemic control and see that the diabetes is under good control. There's an abundance of solid evidence that statins are useful. And I think I want to take you back to one of my first slides where I showed the atherogenic particles, and that could be the explanation. Well, of course, they are affected by statins as well. The VLDL particles are lowered, so there is a small effect there that could be the reason behind that potential effect as well. And then we have the more genuine triglyceride-lowering drugs, the fibrates, that now have big question marks. We have the fish oils, the omega-3 fatty acids, and we have niacin. And I will come back to all of them in a second, but just move on a little bit to see what are we thinking about the future in terms of diabetic dyslipidemia. I think without a doubt, the two first ones are here to stay forever. We need to have good diabetes management. We need to have statins to nearly all these patients. But then the focus should really be on causal therapeutics, using GLP-1 based therapies to reduce body weight, reduce abdominal adiposity that fuels the triglycerides. There is a little bit of hesitancy. We use in GLP-1 based therapies in patients with very raised triglycerides. I think that hesitancy is sort of waning away a little bit, but there is an unfounded, to my account at least, an unfounded hesitancy about the relationship between GLP-1 based therapies and pancreatitis in the situation where triglycerides that you want to lower is also associated with pancreatitis. The evidence for the GLP-1 based therapies and pancreatitis is extremely weak and probably much more dependent on the actual weight loss effect you see there and how that could be actually a general background to pancreatitis. So here is a list of all the compounds and some future compounds that are of interest. We talked about the statins. We have evidence actually both for reducing pancreatitis and reducing cardiovascular disease. One may ask how could statins reduce pancreatitis? Well, it's not reducing I don't believe it is reducing hypertriglyceridemia-induced pancreatitis, but statins do indeed reduce the cholesterol saturation in bile, so it will reduce events of gallstone-induced pancreatitis, and I think that's the signal we see in the studies showing this association. We have the fish oil studies, and I will not talk much about that, but I will point out that this is also an area where the actual evidence for benefit for prevention of cardiovascular disease is rapidly disappearing. So we have the classic fish oils that are extracted from fish and then high concentrated. There is no evidence for protection against pancreatitis, and the latest evidence from such fish oils and cardiovascular disease is also zero. The strongest studies, the strength study, it's completely negative. So again, I take you back to my first slide. Is it about the fibrinolysis, the clotting, or the atherogenic particles? Well, the fish oils do not touch the atherogenic particles. They are there even with the fish oil. They do have an impact on clotting or platelet function. But in these days, when everyone is on aspirin for secondary prevention, how do we know, and those trials have never been done, is the effect of fish oil anti-clotting effect actually superseded completely by the aspirin effect? Fibrates we have talked about. There is no evidence for either. There's no evidence for pancreatitis, but I put a star on my negative evidence there, and that's of course there is no trial to show this because no one has done the trial. So absence of proof is not proof of absence. So we still use fibrates to prevent pancreatitis. This is still a good triglyceride-lowering drug. Niacin has no evidence for benefit against pancreatitis, but there is no studies made there either. It has harmful effects on diabetes. There is no evidence of prevention of cardiovascular disease, so niacin is not the drug that should be used at all any longer. Then I would like to put a little bit of attention of the new drugs that are coming. It started off with quite heroic experiments with LDL gene therapy that was withdrawn for a number of reasons. It involved multiple injections in the thigh of gene constructs for LPL that were short-lived, didn't show benefit in terms of triglyceride lowering, but showed some mysterious reduction in pancreatitis incidence that no one could explain. So that was abandoned. New drugs, volanesorsen, olezarsen, and plozasiran. Volanesorsen is actually on the market and used as it is. It's an anti-ApoC3 silencing RNA therapy. The problem with volanesorsen is that it has a platelet off-target side effect. It really gives low platelets in a large proportion of patients, to the extent that you need platelet monitoring on a monthly basis to keep it safe. It has reduced the uptake of this drug for obvious reasons. And then we have olezarsen and plozasiran. I'll talk a little bit more about olezarsen in a second. We have a host of other drugs that are very potent for triglyceride lowering, but indications are not sought for their use for lowering triglycerides. They're instead sought for MASLD, liver fat, or for ANGPTL3 antagonist for homozygous familial hypercholesterolemia. So I'll come back to these ones in a second. So just a word about the FGF21 and ANGPTL4. These are drugs under development. They lower triglycerides by more than 50%. But the companies that pursue these drugs are not sort of considering triglyceride lowering as a viable option. It might happen in the end when they have been start to be used for MASLD if they are launched, and then you possibly would see beneficial effects long term of. I see I'm running out a little bit of time here. Long-term benefits, so I have to revisit that again. So I will make this extremely short. Olezarsen is a drug similar to volanesorsen, but it's actually using another gene entry target that is specific for the liver. I cut this short and show that this actually has, for the first time, shown a reduction in hypertriglyceridemia induced pancreatitis, massive reduction in triglycerides, odds ratio of 0.12 for pancreatitis, so very, very promising. Final slide, hypertriglyceridemia induced pancreatitis management, low-fat diet is always the mainstay, no alcohol, and it's very, very important to develop culturally relevant advice, practical education and low cost. Patients do not know what triglycerides are. People do not even know what fat in the food is. Many patients don't think oils are fats. There's a need for a lot of practical education when you have to adjust to a very low fat diet. The future can be with other drugs as well. So, to sum up, raised triglycerides is largely caused by insufficient sequestration of fat into adipose tissue. And historically, the management has been about correcting a number. We think beyond that today. We want to see causal mechanisms, evidence-based treatments that deal with the root causes of the raised triglycerides. And there are novel therapies that actually go along that line, and for the first time, there could be effective and causal treatments to treat the most feared of all hypertriglyceridemia conditions, acute pancreatitis. Thank you so much for your attention.
Thank you, Professor Karpe. Could I invite my co-chair, Professor Chandrika Wijeyaratne, to award you a certificate of appreciation?